Why don't we come on up here so we can take questions. I think Lauren's collected a number of questions. And Greta, please join us.
What advice can you offer a patient when they're trying to determine how long you want to stick with one treatment approach? You know, you definitely want to make sure you're giving each treatment enough time to be effective, but you don't want to keep sticking with something that isn't going to be effective.
Since Dan treats one time, and since George just takes the damn thing out so you don't have to worry about it anymore, I guess that's up to me and Pam. We treat, and if we see some significant benefit and some tolerable side effects, we say, well, let's do a little bit more of that. So the you hear about these 6-month treatments. Well, I don't think that makes a lot of sense. We treat, we assess the person. If there's net benefit, we talk about continuing the treatment. At some point, we reach a point where the person says, "Uncle, don't give me that chemotherapy stuff anymore," or we say, "The tumor shrunk nicely. Maybe we'll take a chemotherapy holiday." Or they'll say, or we'll find a scan that at some point shows that the cancer's worse and we know that treatment's not working. So it's really sort of a process of continual reassessment as to whether the treatment should be continued.
Does removing the primary tumor help to prevent or reduce the spreading of tumor cells? And if you remove the primary, will that prevent metastasis?
You want to take that, George?
Sure, absolutely. So I guess the question is probably in the event that you have metastasis, whether removing a primary tumor makes any difference. First, I'll start with the second scenario. So obviously, we don't have metastasis.
Remember, Jeff was here this morning.
So it does not, by the book, it does not affect survival. However, it gives us the opportunity to hit the remaining disease with other therapies, and this is the bottom line. So we very often get a patient who has a tumor in the pancreas and has some metastasis in the liver, and the question is, if we cannot remove the liver metastasis, is it worth having pancreatic surgery to remove the pancreatic tumor? And the answer is, in some selected cases, yes. No, it's not. This is not for everybody, but we do have patients that we have treated that way by removing the primary tumor and then addressing the liver metastasis with either systemic therapy or more often with embolization. And this is where Dr. Z and his team comes in, and with their little catheters selectively feed the tumor with chemotherapy or radiation.
So we will sometimes remove the primary even in the setting of metastatic disease, and even if the primary might not be bulky or causing symptoms, we don't really remove it thinking that that will slow down seeding, which it may very well do. We remove it so that if the only remaining disease is in the liver, we can then concentrate our efforts on the liver and either let Dr. Z at them or even consider liver transplant, which would not be possible if there's disease outside the liver.
Great. How would you treat a patient with thymic carcinoid? In particular, would you consider chemotherapy?
You want to take that, Pam, or you want me?
So, I mean, I think of the data that we have, the large majority is in the small bowel carcinoid tumors and pancreatic neuroendocrine tumors. But as many of you know, there are a smattering of other, even rare among rare, of neuroendocrine tumors. And I think what we end up doing is borrowing principles from what we know about some of the other sort of more common neuroendocrine tumors, if you can say that. So I think that we actually still use some of the same principles of using these same chemotherapies, targeted agents, the sort of biologic medicines that I spoke about, the same principles of surgery, liver-directed treatment. So we actually use very similar treatments.
Yeah, I think because that's such a rare bird, you're not going to find a clinical trial specifically for that, or you're not likely to. We borrow from more common related tumors, advances there we apply to the more rare tumors.
So similar question now for VIP cancer of the pancreas. How would you treat that?
George, why don't you go ahead and start that?
Sure. So VIPoma, as we would probably say, is a cancer of the pancreas that secretes VIP, and this is vasointestinal polypeptide, vasoactive intestinal polypeptide. Patients usually present with diarrhea. These tumors are usually fairly large when they present. They're not occult like other lesions, and they are symptomatic. And we would treat this patient primarily with resection if that's feasible, and most of the times it is. So the resection would be a partial removal of the pancreas, a partial pancreatectomy, either in the tail or the head. These tumors can present in both locations. If there is metastatic disease in the liver, then again the first option would be surgical resection. If debulking, neuroendocrine tumors are one of these few cancers that we are permitted to debulk, meaning remove gross disease, but essentially move up to 90% of the disease. So we would do that with surgery, and then leave the rest for systemic therapy or embolization. If the liver disease is clearly unresectable, then we would, and the patient is still symptomatic, then we would probably proceed with embolization.
So, so basically, whenever you can remove it and feel like you can remove all of it, we say, go ahead, George, do it. If you can remove the extrahepatic disease for the same reasons we talked about, maybe sending the liver, what's left over in the liver, to Dr. Z, we might do that. For VIPomas which cause diarrhea, we might even have Greta help out, and because the diarrhea can be horrible, and we can treat that with octreotide or lanreotide or pasriotide, like Dr. Katz-Nelson talked about this morning, but and with diet. But probably more importantly, if those treatments are not working, then the only solution is to try to shrink the disease or kill enough of the disease, and we could either try that by directing therapy at the liver with Dr. Z or use some of Pam's new treatments. So there's lots of different answers to these, and I wish I could say there was one perfect one.
If a neuroendocrine tumor metastasizes, does the metastasis behave the same way as the primary tumor? So, for example, if you have a pancreatic islet cell tumor and it metastasizes, would you consider that an islet cell tumor, or what would you say about the metastasis? So it's true.
I'll just answer that. It's true for all cancers. We call the cancer by the site of origin. And so if it were a pancreatic islet cell tumor, it still retains those biological attributes of the pancreatic islet cell tumor, whether it's still in the pancreas or whether it's spread to the liver or the lung or the bone or any place else. So it still behaves like a pancreatic islet cell tumor. If it's making VIP or glucagon, it's still doing that. And so, so it doesn't become a liver cancer. So that's a common misperception. It's still a pancreatic islet cell that has spread to the liver. We're not talking about a liver cancer or a lung cancer. It's still the same tumor.
Okay. So next question, if you have an ileocarcinoid tumor, can you predict the time it will take for the tumor to metastasize to the lymph nodes, and then can you predict the time it would take to go from the lymph nodes to the liver?
So this is a brief segue to what Pam will talk about in a little bit, and that is that we don't have an answer to that. It's kind of embarrassing. We just don't have an answer for that. We don't have a good database for all neuroendocrine tumors. So we extract information from the SEER registry, but what we really need is a good database that all institutions will share. And Pam, and with the help of the Caring for Carcinoid Foundation, is trying to establish just that, so that we can get every patient who's had a tumor, and then we can find out how long it takes before we see a recurrence, and what percentage of patients actually do have a recurrence. And that will be crucial information if we ever want to try a drug to see if we can change that. The truth is we just don't have an answer for that, and particularly so for the ileal carcinoids, because many of them are cured with just surgery alone. Or if they're not cured, you have to wait 15 years to see whether they aren't. And so the 5-year follow-ups are kind of meaningless for a disease that grows so slowly.
This next one, I think it's targeted towards you, Greta. Do you have any advice for a patient with short gut syndrome? Is there anything that they can do with their diet to manage that?
Well, that's a tough one. I mean, definitely there's going to be a lot of trial and error, and sometimes people need to be on TPN or IV nutrition, but sometimes we can transition them through different types of elemental diets where the food is, partially broken down already, and that can be a way to get nutrition. Even pancreatic enzymes and some of the other things I talked about can be helpful for that.
By broken down already, are you referring to sort of
so the nutrients? So something like Ensure would be a supplement drink where all of the nutrients, the protein and the fat, are intact. So they're more complex molecules and they require a lot more digestion. but there are specific products where everything is pre-digested. So for somebody that can't tolerate something that requires digestion, we can oftentimes recommend different formulas that are already digested for you, so it makes it a little
That
bit
doesn't mean
easier.
used, by the way.
Yeah.
It's not previously owned.
Right.
Go ahead.
So for patients that have metastases to the liver, and you're thinking about treating metastases in the liver, it would be great to go through how you determine the best way to go at those metastases, whether it's surgery or it's radiofrequency ablation or chemo or radioembolization, and then also in particular, does the number and size of those tumors impact those decisions?
I'll just start to introduce, of course, George and Dan, the fact that that's why it's nice to do it in a setting of a multidisciplinary tumor board, so all the people can be at one table looking at the same scan at the same time and can discuss what each can bring to that particular person and debate whether one might be superior to another, tailored to exactly where that disease is or what the complications might be for that particular patient. And so the rest of it is up to Dan and George, so why don't you guys take it?
Obviously, for metastasis to the liver from neuroendocrine tumors, surgery is the gold standard. However, surgery is not feasible in the majority of patients, as you probably already know and already heard this morning. So only about a quarter of patients are really eligible for complete resection of their metastatic disease. The second problem with surgery is that surgery does not come without a price. So surgery can, obviously, in removing the majority of your liver, can come with morbidity and even mortality. So, and this is what we call, we examine the patient's candidacy in terms of other medical problems, the condition of their liver, and also the extent of the disease in the liver. So this is certainly a multidisciplinary discussion that we have at our tumor board every week for several patients with this disease. And sometimes we will work together to make a patient a candidate for an operation. So sometimes I will ask Dan to embolize a patient's liver before I go in and resect to shrink the tumor so I can make their tumor smaller, so I have to resect a less amount of the liver. Or I can ask George and Pam to give a systemic therapy to stabilize the disease, control the symptoms, or even shrink the disease so we can go ahead with the resection. There are several tricks we have to extend the criteria for resectability. We don't have a defined number of lesions. These tricks sort of come of management of patients with colorectal cancer that are probably more common, but we share a lot of the principles we have for metastatic colorectal cancer of the liver and apply them to patients with neuroendocrine tumors. Sometimes we do, so number of lesions does not matter. What we need is about 2 of the 8 segments of the liver to remain, but we need these 2 segments to have adequate inflow, adequate outflow, adequate biliary drainage, and also we want them to be in good condition so that the liver can regrow and regenerate after our resection. Sometimes we do preoperative embolization of the hepatic artery. As I mentioned, sometimes we do a preoperative portal vein embolization to the liver that we need to resect so that we shrink this part of the tumor that we will resect so the other part of the tumor will already have grown by the time we go in to resect this half of the liver. And again, this is another example of how we work together in managing this patients.
So Dan, tell us what patients you'd like to steal from George for your treatment.
Hopefully none.
We only share, we don't steal. I think, as I had mentioned during the presentation, the things that I can offer, we never sell them as curative. And so if there's any chance that George can cut out everything and cure the patient, of course we will try to collaborate to get that patient to surgical candidacy or transplant candidacy. But there are a number of things to consider. Even if there's only one spot visible in the liver, if you took out that whole liver and looked at it under a microscope, there might be other spots. And a lot of the treatments, the more aggressive they are, like surgery, the more that they can actually stimulate the growth of what's left behind. Because the healing process also releases a lot of growth factors and that sort of thing. And so even though surgery is really the only chance for cure, there's some higher stakes involved as well. If a patient, though, is not considered a surgical candidate, then that patient ends up basically the patient of Dr. Kuntz and Dr. Fisher and mine. And the times that we would consider liver-directed therapy is when the overwhelming involvement of the whole body is centered in the liver. So if someone has a tiny little liver spot, but 50 spots in the lungs, then it does not make sense to attack the liver. So it's only when it's liver-dominant or liver-exclusive involvement. And even then, as we saw, there are several options. So if there's only 1 or 2 lesions, we'll use our microwave oven on a stick and basically cook those 2 little spots. But that's a very unusual circumstance. Usually by the time that we find liver metastases, there are at least dozens, if not hundreds, that are visible. And in that case, we sort of have to carpet bomb the entire liver. And the choice between chemo and radio, again, I cannot honestly tell you which one is better. But if you try one and you don't like it, or your tumors don't like it, then we'll switch to the other.
So to be honest, sometimes there is no one, and even with a tumor board, we may say, well, actually, these are the 3 options that you might think about, and these are the side effects. These are the hope for benefits, and what would be the best sequence of trying them, and then let you decide.
Are there any of these treatments that if a patient has it, it will prevent them from being able to do something else down the road?
So I'll just answer that quickly. Yes, and it depends on how many side effects a particular treatment is. So you wouldn't want to get a big blast of radiation and then think that, well, maybe I can do a big liver surgery. If you're dealing with an irradiated liver, you worry, well, will that liver, go ahead and grow like it normally would? So there may be some limitations as to how we might sequence our tools. Just in terms of eligibility for clinical trials, which is near and dear to Pam's and mine heart, is that certain treatments would make you ineligible for certain clinical trials. So in sort of a strategy of keeping options open, we might go with another treatment that seems equally reasonable so that you're still eligible for a clinical trial that might be coming downstream. Just trying to keep options open.
So, George, you talked earlier about the MGMT as a predictor of response to temozolomide.
Yeah.
So what are sort of the implications on this for patients? Should patients demand that their tumors are tested, or how can they use this information?
Yeah, so it's a very good question, and I brought it up really for research reasons because it hasn't been validated. The numbers I showed you were like 8 patients or something, so we need to get better numbers, obviously. But I will tell you that there was a study done from the Moffitt group in Florida that had 2/3 of their patients had terrific responses, and they didn't even check for MGMT. Now, it might be that those 2/3 were all MGMT deficient, but they didn't even check, and 2/3 is pretty good. So Pam's new trial would incorporate specifically looking at that, and would include those patients outside the pancreatic neuroendocrine world who had MGMT deficiency, so that we could test that. So I wouldn't go back to your doctor and say, I need an MGMT assay.
Great. So is there a role for things like stem cell therapies, cord blood, placental blood in the treatment of neuroendocrine tumor patients, and could that be useful if it came from a family member?
Dr. Kuntz, you want to?
I think this is another one of those we don't know if those potential treatments will be useful for patients with neuroendocrine tumors in the future. I think that certainly stem cell research there's a very active group, particularly at Stanford, looking into that, but I don't have an answer for you right now.
So there's sort of 3 different types of stem cell research, and they're really very different. One type is the old embryonic stem cell, the kind that George Bush banned. That's the true stem cell that can give rise to the entire human body. And learning about the processes that dictate how a single cell can become all the elements in the human body is critically important to understanding cancer, but it's probably not going to give us the answer for cancer or the replacement for body parts. There's a second type of stem cell, and there's the stem cells from tissues. And that was alluded to by a question earlier. Can we have a stem cell for the intestines so that we can regrow our intestines if we have to take them out, or a stem cell for the liver? People are working on that and actually making some fair bit of progress, but we're a long ways from being able to regrow an intestine or something like that. And then the third area is stem cells that are tumor stem cells. The concept is that maybe 99.9% of the tumor cells in a tumor are like worker bees, and that this is a beehive, and that those are worker bees, and that there are only a handful of queen bees in that hive. And that concept has some proof in some tumors, and it may be that if we targeted those queen bees, eventually the worker bees would die off and we'd cure the cancer. So there's a lot of work being done looking at cancer stem cells, seeing if they have specific targets that might represent an Achilles heel in the cancer. And in fact, we have the first antibody directed against a cancer stem cell target that we're testing in phase 1 studies right now. Now, that's not to say that it's working great or that we know it's going to work, but it's another completely different avenue of research that tries to exploit the concept of stem cells.
Can you talk about treatment of metastases to the bone and brains and how you can go about treating those and when you should treat them?
Pam, you want to do that?
I'll start with that. So I'll talk about the bone first. So bone is an area that the systemic chemotherapies and these sort of targeted biologic therapies I mentioned do access. So when we give a systemic treatment that's through the blood, that goes everywhere. Sometimes that also includes the brain, but typically there is something called the blood-brain barrier. It's very difficult for sort of big molecules like chemotherapies and antibodies to pass through that. So typically we have to use other mechanisms for treating brain metastases, the most common of which is radiation directly to the brain. And we're certainly looking for other ways, but there are some chemotherapies that will get access to the brain in those situations. Another thing, in terms of metastatic disease to the bone, there are ways that we can protect the bone. So bone metastases will often weaken the bone and predispose people to getting fractures. There is a medicine called Zometa that can help protect the bone and strengthen the bone. And then we'll sometimes also use radiation to the bone if people are having symptomatic pain, or particularly to strengthen bony areas with metastatic disease. I don't know, George, if you have other comments.
No, that's what I do too.
I would add one more thing about the bone mets, especially if they're painful. The microwave oven on a stick can also work to get rid of the pain, and then you can replace the bone with basically an acrylic cement that helps to strengthen the bone as well.
It's good for spine mets. But I want to caution you because many people, not many, there are patients with neuroendocrine tumors who have spots in their bone on a scan that will never be a problem. And so you don't want to overreact to a spot on a scan.
Can you discuss the most effective or the most promising treatments for non-functioning atypical carcinoid of the lung that's metastasized?
I'll try that one too. So non-functioning atypical carcinoid of the lung, again, even though Terry Longacre, our pathologist, will do her best to guess which tumors are aggressive and which ones are not, the best way of addressing that is time. And so if we have the luxury of observing a person over time and seeing that the tumor is not growing, that trumps any pathology test. So if in fact that tumor might be stable, as some atypical carcinoids can be, then that person doesn't need anything very aggressive or certainly doesn't necessarily need aggressive chemotherapy. On the other hand, if there is growth or if there's a large volume of disease where you worry about a little bit of growth causing problems in short order, you'd be more inclined to give chemotherapy. If you could, I said, I guess I would give chemotherapy plus one of the targeted agents, although that's pure speculation.
Can you clarify something that Dr. Kwan spoke about earlier, especially when you would use an Actria scan? Would you only use this if blood and urine levels were questionable, or are there other instances when you would use it?
I don't personally like octreotide scans as fishing expeditions. Because you saw, I sometimes accuse Andy Kwan of having a vivid imagination. You saw those pictures that were kind of, gray blobs, and he said, oh, well, here's the tumor. Now, of course, he was absolutely correct, but but you can see gray spots in different places and say, well, maybe that is, or maybe that is. And so there can be false positives even on an octreotide scan because the normal bowel will have a little bit of uptake. The bladder always, the bladder can as well. In any case, I think that the situation I would use for that is if I had a CT scan that looked abnormal and I was trying to figure out, well, is that abnormality neuroendocrine tumor? And if that abnormality picks up octreotide, it almost certainly is. If that abnormality is small and not growing, and it's been stable over a long time, I'm not sure I even need to know what the octreotide scan does because it could be a neuroendocrine tumor, but if it's not growing, not causing problems, I'm not entirely sure it needs a treatment. So I think it's good to step back and say, well, why are you actually doing the scan? Seeing something isn't necessarily enough. It's how would that scan's results affect your management of the person in front of you? Would it help determine a prognosis? Would it help define whether surgery should be done? Would it trigger you to give chemotherapy? And the octreotide scan itself is not necessarily a great indicator for that.
Please.
Yeah, just one comment on that. That I think where octreotide scans are not recommended is to do those routine surveillance. So I would not recommend doing every 6-month octreotide scans.
Right.
In fact, that's part of the NCCN national guidelines, is that it's much better for those surveillance scans to use something that gives much more anatomic detail, like a CT scan or an MRI.
Yeah.
And so kind of on this imaging line of questioning, how important is it to find a primary tumor if you have known metastasis? Can you treat the metastasis, particularly to the liver, without knowledge of where the primary tumor is?
Dan will treat the liver no matter what. I would say that I would question even the 30 cases that Dan mentioned as being neuroendocrine tumors of the liver. I don't personally think they occur. They just couldn't find out where it came from. And it probably came from the small bowel someplace because it can hide there as tiny, tiny something and then spread to the liver. And just like seeds that may find more fertile ground, it may have found a happy place to grow in the liver, and where it originated just wasn't growing at all. But if it's still liver dominant, it fits Dan's rules of treating the liver, and certainly Pam would offer the person chemotherapy. In fact, we have put people on clinical trials with liver disease where we never found the primary, as long as they fit the eligibility criteria elsewhere. You want to comment on that?
I would add also that this is not unique to neuroendocrine carcinoma. So this is a much more common metastasis to the liver is from the colon. And there are something like 56,000 Americans that die every year from colon cancer. But you think about it, what do they actually die of? They don't die because their colon ruptures. They don't die because their colon gets plugged up and they get full of food. A majority of these patients actually die because the colon cancer spreads to the liver, and the liver gets affected and goes into failure. And so for both colon cancer as well as neuroendocrine, it does not always make sense to be maximally aggressive against the primary, because the primary is not always what kills you. Frequently, it's the liver involvement that kills you.
Now, if we thought that we might move towards a liver surgery, we'd hunt even harder, and that's what George would be looking at if we had liver mets with neuroendocrine tumor. He'd probably look around. In fact, we've even gone so far as to do. We haven't done it recently since you've been here, but we've given octreotide, and we send the surgeon in with a Geiger counter, and looking, which is even more sensitive than the octreotide scan, to try to find a primary sometimes.
Right.
Want to comment?
Also, when we can do exploratory surgery to really find the primary tumor in the small bowel or the pancreas, and sometimes this is what we have to do, especially if we are going in to treat the liver either way. But obviously, we need to try to find the primary tumor, and because this will also give us more information about the disease itself.
Do you want to plug in the biobank slides? No, go ahead.
Yeah, just a couple more. Is it possible to study carcinoids?
You want to speak in the mic there?
Is it possible to study carcinoids in the body of a deceased person?
So there are numerous aspects of that, and I don't want it to sound as morbid as it sounds. autopsies can be very important in learning about a disease. And so it's not uncommon that people have offered to me, say, well, I want to donate my body. And so if there's anything that you can learn from it, please. And I'd love to say that we could learn more frequently that way, but that's not always the best way. In somebody who, and Hopkins actually has what's called a rapid autopsy service to try to get people as soon as they have died so that they can learn as much as they can. But what's better than that? What's important and better than that is getting the tissue in the people while they're alive and storing it appropriately so we can interrogate that tissue, so we can read the DNA, so we can look at the proteins, we can see where the Achilles heels might be for that tumor, and then we can start applying that with our data, with Dana-Farber's data, with Memorial Sloan Kettering's data, with MD Anderson's data, and then looking at it together. And that's a good, I think, segue to what Pam's going to talk about. So tissue is key. Understanding what's in the tissue is key. I'd much rather get it from the first surgery, which is another reason I think to have your first surgery, if you can, at an academic center where we keep the tissue forever and we freeze it. That doesn't happen in community hospitals. It happens with every patient who goes to UCSF, and then you have the luxury of seeing Greta too. But they freeze the tissue, we freeze the tissue, and we keep it forever.
Did you say at UCSF they do that?
We do that. UCSF, every academic institution does that.
So I was the one that asked the question, and I'm just curious. 13 years ago, Dr. Norton saved my life. 20 tumors in it. UCSF. And I'm thinking now it's back after 12 years, and Dr. Kuntz is treating me. If that evidence is there, and I got killed in a car wreck, if I had it written down that tumors would come, so it's possible that they could be checked back. So
UCSF will still have that tumor, even if it was 13 years ago, stored forever. Understanding that there may be a study that we want to take a section of that and understand more and see, my goodness, here's somebody whose tumor came back at 12 years. Could we have predicted that based on looking at the DNA in the tumor? And if we could, then we could tell people, let's see, this is how much time you have, or these people have a shorter time to recurrence. Maybe they're the group that we want to try some chemotherapy on to see whether we can delay or improve the overall outcomes. So the tissue is the issue. That is one of the most important things we can do, and especially for this tumor, which is number one, rare. Number two, we don't have animal models. If we had a ton of animal models, we might be able to make some inferences from the animal models, but we don't have good animal models. So we need to learn as much as we can from the biology of the tumor that is already there. So Pam, why don't you go ahead and... Oh, and I should thank you very much for coming. I don't want to keep them any longer, so.